last speaker for the rapid fire session is Dr. Ramin Jamshidi. He's a pediatric surgeon at Phoenix Children's Hospital. He's a director of pediatric trauma at Maricopa Medical Center and assistant professor of surgery for Mayo Clinic. Dr. Jamshidi.
All right, good afternoon, and thank you to the Planning Committee for the invitation to be here with you today. We're going to cover some scattered topics in pediatric trauma and kind of highlight how they differ with adult care. We'll spend about half the time on dialing down drug doses and half the time on smaller incisions. Now, come on, it's going to be a lot more interesting than that, but I'm not selling you anything. All of this is going to be directly clinically relevant, and we've got about 10 minutes to bounce through a couple of topics I've put together. So first thing I want to talk about is some patterns of injury which differ significantly and in very relevant ways between pediatric patients and adult trauma patients. So if we start with chest injury, we see blunt chest injury, we see a lot in motor vehicle crashes. In our adult patients, we're particularly concerned about mediastinal vascular injury, severe injury to the mediastinum. This is the predisposition to these injuries is significantly different in children because of the anatomy, the compliance of the chest wall, and the honest-to-goodness mobility of the mediastinum itself allows these patients to literally be more resilient. They are able to absorb traumatic forces better and thus not transmit them in harmful ways to the tissue. So this has been well recognized and well demonstrated. The incidence of mediastinal vascular injury in pediatric blunt trauma is exceedingly rare. This was a big series out of the National Trauma Data Bank, and it turns out it's about 1 in 8,000. If you do the quick math, that's 0.0125%. And even then, the mean age of injury was 16 by ACS trauma. That's an adult patient. So if we move up from there to the cervical spine, the incidence of injury to the cervical spine is also several-fold lower than in adult patients. Sort of interestingly, there's also incidence and characteristics that are highly dependent on the age of the patient. So incidence is, it's almost a tenfold lower prior to adolescence than it is in adults. And then from there, there's a steady rise to the teenage years up to the adult levels. Particularly curious is that in the very young children, infants, toddlers, preschoolers, the injuries tend to be very high in the C-spine and uncommon in the lower C-spine. This has significant relevance for your evaluation and where you focus your imaging. This has been repeated. This study was out of the National Trauma Data Bank. This one is out of the PCARN network, and this is a well-recognized fact. So if you then think about by patterns of injury, how you guide your evaluation and management for a patient, and we can stick with C-spine, the indications for C-spine imaging in children is really pretty much the same as it is in adults. If you look at how we evaluate, how we image, that's a bit different. So in adults, we CT. I can't remember if it was 8th or 9th edition of ATLS that was solidified as this is the standard, but it was a decade ago that these series were being published. These are all collected series out of Journal of Trauma from the last decade that clearly demonstrated that plain films are inadequate for evaluation of cervical spine trauma in adult patients. However, that is not the same as a pediatric patient. Even if you set the incidence aside, there is no standard for evaluation of these injuries in pediatric patients. The features, the limitations of plain radiography in adult patients, really most of them don't apply in the pediatric realm. And yes, we do have concerns about radiation exposure, particularly when you're talking about dense dose right over the thyroid, and the greater susceptibility to radiation, long-term radiation attributable neoplasia when exposure is earlier in life. A 5-year-old has something like, I can't remember off the top of my head, 6 to 8 times the incidence of attributable malignancy than if you got that same dose of radiation in your 20s. So This has been evaluated, this has been looked at. The hard thing is if you've got an incidence of injury of 1%, you need to amass a tremendous number of patients so that you actually have enough injuries that you can evaluate your diagnostic algorithm. This is again out of the PCARN network, and they had 206 patients with verified cervical spine injuries from blunt trauma, and when they excluded the patients who had technically inadequate films, it was inadequate radiography, they found a sensitivity of 90%. Now, 90% isn't totally awesome, but if you look carefully at the cases that were missed by plain radiography, a lot of those were actually non-displaced spinous process, transverse process fractures, and a small proportion were also high cervical injuries and atlanto-occipital injuries in the very young patients, which you could address separately. If you take another step back and say, well, why do you even image? Who can you not image? This was a study published in the Journal of Trauma about 2.5 years ago that garnered a lot of attention because they had, for this problem, a decent collection. They had 22 patients with injury, several hundred patients, 22 patients with C-spine injuries, less than 5 years old. About 85% of those injuries were C4 and higher, as I've already told you. And they found that all of these patients had a clinical indication for imaging. It was not empiric imaging. So they concluded that in this age group, if you did not have that a reliable clinical exam, just as you would do for an adult with Nexus, didn't provide an indication for imaging, then you could clinically clear the cervical spine of injury. So much lower incidence of injury, very interesting and important dependence on age with regard to the characteristics of the injuries. And so I encourage people, this is going to be the most debatable or sort of evolving area that I'm touching on and the things we're going to go through in these 10 minutes, is that imaging is not always necessary and plain radiographs can be reliable. This is in evolution as we speak and debated at our pediatric trauma meetings. Going back to the issue of blunt mediastinal vascular injury, that's a problem. This patient has a widened mediastinum, needs more attention. But as it was recognized that these injuries are exceedingly uncommon in pediatric patients, people started looking the last several years as to whether you even needed a CT of the chest at all, absent a widened mediastinum. Folks in Tennessee looked at it and put out a decent publication. The folks in Colorado put out a decent publication, and this one's referenced most frequently. And they found that there were no chest injuries that required emergent or urgent intervention, which were not identified on the plain radiograph. Meaning, if you have a normal chest x-ray in a pediatric trauma patient, you probably don't need a CT of the chest. That's not to say that there aren't missed injuries, and I put it up there, it's the same between the two groups. It's about 60% sensitivity of chest x-ray for the injuries that were identified on CT. But you can guess why that is. It's because there were a bunch of non-displaced rib fractures and occult pneumothoraces that were identified on CT, nothing that made a clinical difference for the patients. So this is a pretty widely accepted standard now in pediatric trauma care that if you have a normal chest x-ray that's been properly interpreted considering pediatric variants, you do not have a reason to obtain a CT scan of the chest unless there is a specific concern, a specific indication that you are looking to pursue. So if you've got a wide mediastinum, right, you're going to get a chest CTA. So if we switch gears again and now talk about management and a touch on solid organ injury, because this is just a totally different paradigm in pediatric care than in adults, and it's really very curious. Splenectomy is uncommon. It should be uncommon in pediatric patients, so much so that it's used as a quality indicator in an analysis of pediatric trauma center performance. And in national level studies, it's been demonstrated that for the same grade of injury, you are twice as likely to undergo splenectomy in an adult trauma center than in a pediatric trauma center. That's contemporary data. That's not 20 years ago. That's a few years ago. And the reason for that, there's no magic in it. I think that's because if you're used to, there's no pointer here, but it's because if you're used to sitting on your hands looking at this, then you're more comfortable sitting on your hands looking at this, because it gives you angst when you're looking at your adult patient and they've got this scan, particularly if you see, I can't jump high enough to show you, but you know, there's a little bright spot next to that spleen. There's a little blush of intravascular contrast, if you will. Here's the most mind-bending thing that I'm going to tell you in these 10 minutes, the blush in pediatric patients. If that's my adult trauma patient, we're either on our way to the operating room or we're calling in IR. In a pediatric patient, it actually doesn't matter. It's not predictive of failure of non-operative management. I can't understand it. That's all I can tell you. It doesn't make sense, but it's not predictive at all. So solid organ injuries rarely require operation in the pediatric population, even when you're talking about grade 4, grade 5 spleen, liver. A blush is not an ominous finding. It doesn't commit you to a certain course of action, and your management should be guided by the hemodynamics, not by grade of injury or imaging features. And that's all really been studied and codified very well by the Atomic Collaborative. The last gear I want to switch to is to talk briefly about injury prevention. And there's been, for a variety of reasons, a lot of attention on firearm safety and firearm injuries of late. And we looked over the last 10 years at the only level 1 pediatric trauma center in the state of Arizona. We looked at our 10-year experience, and we had 171 firearm injury victims. And if you exclude the 35 that were suicide attempts, you may be surprised to find out that what we were looking for was the age of the shooter. Over 90%, the shooter was a minor as well. The shooter was under 18. This may surprise you. It wasn't all the teenagers. 45% of those shooters were 9 years and younger. I think that's pretty dramatic. And these are big numbers we're talking about, and has important implications for injury prevention and how that differs in children than adults. So we've sped through, we've covered a lot of ground. I hope it was interesting. And I hope it demonstrated, at least briefly, some areas where it really are not just smaller patients. With that said, I will concede there are weeks where I swear I haven't operated on a patient who's less than 100 kilos. And we have some of these little people trapped in big bodies. And it is important to consider, particularly when talking about things like blunt chest trauma and massive deceleration forces, that a patient with this habitus, probably the anthropomorphics, the mechanics and the size and the mass and the momentum in that body are more relevant than the chronological age. But thank you for your time and attention. Appreciate it.